Good afternoon. I'm Dr. Bob Hopkins. I'm the chair of the National Vaccine Advisory Committee. Thank you for joining us virtually for today's second day of our February NVAC meeting. I want to thank you, Anne, and the NVAC team for your work in planning this meeting and supporting the committee throughout the year. I also want to thank the NVAC members and our subcommittee members for their dedication to further the work of this committee. I look forward to the presentations and discussion today. I want to begin with a few housekeeping items. In terms of housekeeping, I want to make sure everyone is aware this is a public meeting and it's being webcasted on the HHS website. Please remember to mute yourself when not speaking, and please do not use your camera unless you're presenting, asking questions, or answering a question. During discussion, I'll ask that all members and speakers identify themselves before speaking if I didn't acknowledge you by name and giving you the floor. This helps the note taker and others to follow along. Throughout the day, there will be opportunities for committee discussion. If you'd like to ask a question or provide a comment, send me a message through the chat feature or raise your hand through the portal. As always, members of the public can provide a public comment by phone at about 5 p.m. today. Public comments are not a question and answer session. They represent an opportunity for individuals who'd like to make a statement to do so. The deadline to request space for public comments during this meeting has passed. However, anyone can submit a written comment up to 3 pages in length to NVAC@HHS.gov. I want to start with a few highlights from yesterday's meeting. We began the meeting with 2 interesting presentations which emphasized that COVID vaccine benefits and protection from severe disease is likely much more than neutralizing antibody titers. Cell-mediated immunity, both T-cell and B-cell plasma cell responses, are important and warrant further study. In addition, we have challenges in developing future vaccines which will provide better lasting protection from infection, in addition to our current successes protecting people against severe disease. Our Innovation and Immunization Subcommittee has jumped into their work with both feet and will continue their work in response to the AS's charge. The Long COVID panel provided us with important information on the federal government response to supporting patients with long COVID and the research agenda to better understand it, followed by presentations which provide some insight into the epidemiology and potential for vaccines to reduce the impacts of long COVID. And we all need to continue to emphasize that the best treatment for long COVID is not to get COVID. Following a short break, we had a very informative panel presenting about the great advances made in RSV vaccines and monoclonal antibodies and the potential for vaccines to be available for use in the near future to reduce the impact of RSV in infants and older adults. Our last speaker of the day, Dr. Maishika Roberts, updated us on the measles outbreak in Central Ohio, reminding us that we can easily see outbreaks of vaccine-preventable disease with slippage in our vaccination rates. Now for some highlights of today's meeting. We will host panels focused on the safety and accessibility of available vaccines. First, we'll have a panel on vaccine acceptance within the LGBTQI+ community. Next, we'll hear from experts about COVID-19 vaccine safety. We'll follow this with a brief update from our Vaccine Safety Subcommittee. After a short break, we'll resume a panel on improving coverage and lowering costs of vaccination to improve adult immunization. And the final presentation will focus on the vaccine's federal implementation plan. The day will conclude with our federal agency and liaison representative updates and public comments. Finally, as a reminder, please hold the remaining 2023 meeting dates on your calendars. Our next meeting will be June 15th, 16th, and we will also meet September 21, 22. Please refer to the NVAC website for details on these upcoming meetings. At this time, I'd like to start our first panel of the day titled Protecting LGBTQI+ Communities, Addressing Gaps in Immunization. In this session, we'll hear from Tari Hahnemann from the Human Rights Campaign. Tari is the director of the Health and Aging Program and oversees the annual LGBTQ Healthcare Equity or Equality Index and other projects related to health and aging. Jennifer Keith is the deputy director of the Research and Evaluation Group at the Public Health Management Corporation. Jennifer will discuss some vaccination-related findings from a large needs assessment in Pennsylvania. Kristen Flickinger is the executive director of the Pacific Pride Foundation. She will discuss her efforts to prevent mpox and respond to misinformation. Dr. Henry Meg has many roles at the Cleveland Clinic, including directing the Center for LGBTQ+ Care. They are a physician educator and advocate and will share thoughts on HPV vaccination in the LGBTQ+ communities. And Christina Graham is the Data and Evaluation Manager at the Bradbury Sullivan LGBT Community Center. She's a public health researcher who's passionate about using data to inform programs. She will discuss how her team utilized the needs assessment Jennifer Keith is presenting on to support health education and services. Our first presenter in this panel is Tari Hahnemann. Tari, your slides are up and you have the floor.
Thank you. Good afternoon. I would like to start off by thanking the committee for having this panel and for considering the vaccination needs of the LGBTQ+ population. My name, again, is Tari Hahnemann. I'm the Director of the Health and Aging Program for the Human Rights Campaign Foundation, and I use she, her pronouns. The Human Rights Campaign is the nation's largest LGBTQ+ civil rights organization with over 3 million members and supporters. The Human Rights Campaign Foundation is the educational arm of HRC, and it works to improve the lives of lesbian, gay, bisexual, and transgender people by working to increase understanding and encourage the adoption of LGBTQ inclusive policies and practices in the places that impact people's everyday lives. We do this through a variety of educational programs, research, and technical assistance resources. So my role today is to help provide an overview of the LGBTQ population and some of the needs and concerns as it relates to healthcare and vaccination. Perhaps the next slide, please. It is estimated that there are at least 20 million LGBTQ+ people in the United States. And I say estimated because the official tool to count the U.S. population, the United States Census, does not ask a demographic question about whether or not someone identifies as lesbian, gay, bisexual, or transgender. So this estimate largely comes from the Gallup Daily Tracking Survey, which does ask that question. In addition, the census does ask about same-sex households and has recently added a question about to their household pulse survey that found that nearly 8% of the total adult population identify as LGBTQ. Both the census and the Gallup data poll found that LGBTQ people live in every state and community with an average of 7.1% of the population identifying as LGBT. So it's fairly safe to assume that all providers are going to have some sort of LGBTQ patient population. Unfortunately, the census is not alone in measuring the LGBTQ population. So the greatest challenge in measuring health outcomes in LGBTQ individuals is the fact that it's largely not being done. We like to say that if you don't count us, we don't count. And for too many years, the LGBTQ community has not been counted when it comes to health outcomes. And while there has been great progress made in adding sexual orientation and gender identity or SOGI data to various surveys, research protocols, electronic health records, etc., there is still a really long way to go. Next slide, please. When we do measure the LGBTQ population, we have consistently found that bisexuals typically comprise at least as half of all of those who identify as lesbian, gay, or bisexual, making the bisexual population the largest single group within the LGBTQ+ population. Transgender people and people of color comprise large portions of the bisexual community, with more than 40% of LGBT people of color identifying as bisexual and about half of transgender people describing their sexual orientation as bisexual or queer. And while bisexuals may be the largest group, they are also the most invisible group. Many people will assume that a bisexual person is either straight or gay, depending on who they are partnered with at the moment. There's also a tremendous amount of biphobia, both within and outside of the LGBTQ+ community. Bisexuals face major health disparities and poor healthcare outcomes from a lack of adequate preventative care. Next slide. As you can see here, there are also generational differences in the self-identification rates of LGBTQ folks in the Gallup poll, with Generation Z having nearly 21% identifying as LGBT. The high rate of LGBTQ self-identification reflects a combination of increasing cultural acceptance for LGBTQ people and the fact that Gen Zers are increasing as a portion of the national population of adults while older generations are decreasing. And in addition, Gen Zers are also more likely to identify as bisexual. Next slide. So LGBTQ folks face a variety of health disparities and access to care barriers. Some of these disparities are related to the external stigma related to stressors such as everyday discrimination, victimization, microaggressions, and violence that disproportionately impact the LGBTQ population. There is a stereotype that LGBTQ people are wealthy, but when you look at data from various sources, LGBTQ people have higher rates of poverty than their cisgender straight counterparts, and they're also more likely to be uninsured. Bisexuals and transgender people in particular are more likely to be underinsured and have less access to health care, and nearly a third of transgender people have no regular doctor. One important demographic fact that I haven't touched on yet is the fact that LGBTQ people can be found in every socioeconomic and every racial and ethnic category there is. So it's really important to apply an intersectional lens to the population and recognize that people will have many overlapping identities that will each carry their own oppressions and privileges, and that those with multiple marginalized identities are the most likely to face access to care barriers and have adverse health outcomes. Next slide. The landmark Lambda legal study when healthcare isn't caring found that 56% of LGB and 70% of transgender and gender nonconforming people have experienced serious discrimination in healthcare. Because of this discrimination, this history of discrimination, or even fear of facing discrimination, LGBTQ+ people are more likely to delay or avoid seeking care because of fears that they will be refused care or discriminated against. In fact, LGBTQ people are 3 times more likely to avoid medical care, and this is even more pronounced among transgender people and LGBTQ people of color. Next slide. So one of the ways that my organization is working to address this discrimination is through our Healthcare Equality Index, which works with hospitals and other healthcare facilities to help them adopt LGBTQ inclusive policies and practices. Full disclosure, the API does receive some funding from pharma and Pfizer. Next slide. The API measures a number of policies and practices, and over the 15 years of the API, we've seen tremendous growth in both the number of healthcare facilities that are participating, as well as the number of LGBTQ inclusive policies and practices that they have adopted. Next slide. So I'd just like to end and very quickly touch on some of the COVID-19 research that we have done at HRC. At the beginning of the pandemic, HRC released a brief highlighting the potential for elevated risk for COVID-19 faced by LGBTQ Americans, and since then has actively engaged in research to monitor and understand the impact of the pandemic on the physical, mental, and financial well-being of the LGBTQ community in the United States. The research that I want to highlight today focuses on vaccination and booster rates, and it's from a series of surveys conducted between July 2021 and May 2022. Next slide. So fortunately, despite all of the barriers to care and fears around healthcare that I discussed earlier, and which very much create the potential for low vaccine confidence and coverage, our research found that the LGBTQ population was substantially more likely to be vaccinated and boosted than the general public. A 2021 report using the National Immunization Survey Adult COVID module also had similar findings. Next slide. And this slide just talks about some of the reasons that the LGBTQ population have vaccinated, but they're largely driven by the desire to protect themselves, their families, and the broader LGBTQ community. So on behalf of the LGBTQ community, thank you again, and I'll pass to the next presenter.
Thank you very much, Ms. Hahnemann. Our next presenter is Jennifer Keith. Jennifer, your slides are up. You have the floor.
Thank you so much. I want to thank the committee for having us today. This is really an honor, and to be on such an amazing panel is a real pleasure. So thank you all. My name is Jen Keith. I use the she and her pronouns. I'm going to be talking about Pennsylvania today and a large statewide needs assessment that we've conducted here. We can go to the next slide. You know, if we're thinking about like why have a statewide panel, well, this is really aligned with national goals, with Pennsylvania goals, to really think about health equity and attaining the highest quality of health for all folks. If we go to the next slide, you'll see part of our foundation here is that Pennsylvania has for many years been working on shining some light on often invisible LGBTQ communities. And we've also had the pleasure of working with our former Pennsylvania Secretary of Health and the current Admiral Levine. She says it best when she says, it's true, we haven't made progress unless we've all made progress. So this is where we're building from and thinking about ensuring that the LGBTQ community has some data and isn't just disappearing because we haven't asked the right questions. Go to the next slide. So starting back in 2015, we started piloting regional needs assessments. And then in 2018, we moved to a statewide assessment. 2020 and 2022, we've continued. So this is our biennial survey. In 2022, we talked to folks who are residents of Pennsylvania who identify as LGBTQ, ages 13 and over. We asked about all types of things, so including experiences with healthcare providers. Tari really started talking about that. We'll really emphasize some of those pieces. Mental health, substance use, tobacco use, all kinds of different things, and certainly vaccinations. So I'm going to tell you a little bit about those, but I'm going to give a little bit of background first. We have feedback in 2022 from over 4,220 respondents, and this was really spread in we got to almost every single county in Pennsylvania. And we make sure that these data, we're presenting a little bit here today, but we have a publicly available report. You'll see the link at the end here. We make sure these data can get to researchers, healthcare providers, government agencies, and of course, the LGBTQ community itself. Go to the next slide. Just a little bit more about the survey. It was conducted in English and in Spanish. We consider it a meaningful, purposive, convenience snowball-style sample. And if you remember nothing else from this presentation today, it was so important to work with our LGBTQ community-focused, community-based organizations. So that was a key reason for this even being able to be pulled off at all. A couple other notes here, but I'll just go to that next slide and show you a list of that we're not joking around in Pennsylvania when we say we're working with LGBTQ communities. We have so many different partners who supported outreach and media, and you'll hear from Christina Graham in a little while, who was the mastermind behind so many of these connections and ensuring that we have a well-rounded and meaningful sample. We'll go to the next slide. We added each time we do this, we add some new topics. We talked about neurodiversity, disability, sleep, and the COVID-19 vaccination for the first time in 2022. And then, of course, we're expanding other topics each year, so including sexual health, mental health, healthcare providers, barriers to care, and tobacco use. We'll go to the next one. So we have a universe here. The next sets of slides, we'll be talking about this large group of over 4,220 folks. We'll go to the next slide. Tell you just a little bit about the general things that we found. So 1 in 4 respondents described their general health as poor or fair. And in alignment with what we've already heard so far, 5 in 10 respondents fear seeking healthcare services because of past or potential negative reactions from healthcare providers. That's certainly relevant as we're thinking about vaccinations and access to those services. But there's also some really positive news and resilience that we were seeing, and 96% of our respondents shared that they had some kind of interest in healthy living strategies. So this could be ending their tobacco use, or getting a vaccine, or increasing their fruits and vegetable intake. So there's not a lack of interest. We do see in some of our most well-known preventative strategies of fruits and vegetables and exercise on this slide, we are not yet reaching the daily recommendations. So there is still work to do here, but just wanted to kind of give that overview as we're thinking about, the vaccine specific slides that are coming up. We'll go to the next slide. And because we're going to be talking about vaccines, I wanted to make sure we shared that almost 1/3 of our respondents experienced a negative reaction from a healthcare provider when they learned they were LGBTQ. And this happens significantly more often among certain groups within the LGBTQ communities. So this happens more if you're read as LGBTQ in public, if you are transgender or gender non-binary, if you identify as disabled, or if you identify as neurodivergent, autistic, or on the autism spectrum. So we have a health disparity, and it's all exacerbated even within the LGBTQ community. So this is really, really important for us to consider as we're offering vaccines, as we're thinking about where those vaccines can be attained. Go to the next slide. We'll start with the flu vaccine. This is a longstanding public health measure. We found that almost half of respondents had not had a vaccine, so 47%. But folks were largely going in and seeing some kind of healthcare provider for a routine annual checkup. So while there's 3/4 of folks who were going in to get care, just under, or about half are really getting the flu vaccine. So there's some kind of disconnect here that maybe we can address and improve as we move forward. Go to the next slide. When we think about the COVID-19 vaccine, it was a different story. We had more than 9 in 10 respondents report being fully vaccinated for COVID-19 at the time of this survey, which was spring of 2022. So this is, more than 3,600 folks. More than 8 in 10 of those who were fully vaccinated also received a booster. And another 1 in 10 plan to get a booster. So there was a very high receptivity. This is very aligned with the first presentation from this panel. And a really important note here is that community-based organizations across Pennsylvania, including LGBTQ serving organizations, partnered with local health bureaus and healthcare networks to provide COVID-19 vaccinations. So you could get a COVID-19 vaccine in a variety of locations, not just with your healthcare provider. Go ahead to the next slide. We did have a small number, about 160 folks in the full survey who were not fully vaccinated, and when asked about those reasons why, the most common reasons were a worry about side effects or for safety. This was important for us to look at, even though this is a smaller number. There was a lot of concern about maybe there was some logistics that were keeping folks from getting vaccines. That was a very low percent who said they didn't have a ride or they weren't sure where to go. Go to the next slide. As we think about Hep A and HPV vaccines, we have over 1/4 of respondents said that they had not received the Hep A vaccine. But what's an even more interesting finding is that over 1/3 weren't sure if they had the vaccine for Hep A. So there may be some identity or branding or some kind of communication that's going to be important here for Hep A to get on the radar of communities across the board. When we're thinking about HPV, almost 1/2 of respondents reported not having received their HPV vaccination. But as we're thinking about age, that is, recommendations here. If we just looked at the folks who were through age 26, among that age group, 57%, more than half, had received their HPV vaccine. So slightly more, but there's still room for improvement there. Go to the next slide. So it's always going to be really important for us to be thinking about opportunities to share information and to make sure that we are leaning into trusted community resources. That's going to help us close service gaps and reinforce support systems. A lot of folks need to get involved, not just LGBTQ folks themselves, but also community agencies, government agencies, allies, all types of individuals can help us improve vaccination rates and just health overall within the LGBTQ communities. And then regular feedback, making sure we're listening and gathering additional information over time is going to be critical. Go to the next slide. In our full report, we have a series of recommendations. Certainly, we want to highlight the support and fund chronic disease prevention, as that's where vaccines come into play for sure, even though they run across many of these recommendations. And as I mentioned in the very beginning, partnering with LGBTQ community-based organizations is so critical to success and can really be just the make or break point for any kind of services. We'll go to the next slide. I want to share the fellow authors on this report. Special thanks to folks who helped us out in different ways: Adrian Shanker, Dr. Dahlk, Dr. Scout, and certainly to the Pennsylvania Department of Health and the Division of Tobacco Prevention and Control for their support and funding for this project. And the next slide will show you a way to get to the full report, and you can scan the QR code or use the short link. Thank you so much.
Thank you very much, Jan. Our next presenter is Kristen Flickinger. Kristen, your slides are up. You have the floor.
Great, thanks so much. I'm Kristen Flickinger. I use she, her pronouns. And I do want to say thank you as well for having us here to address the needs of the LGBTQ plus community. Pacific Pride Foundation is dedicated to ensuring a vibrant, thriving, and visible LGBTQ plus community in the Central Coast of California. We're a medium-sized center, and we're one of hundreds of centers like us across the country. Next slide, please. So today I'm going to be representing, yes, Pacific Pride Foundation, but also other community-based organizations who serve LGBTQ plus communities, specifically other LGBTQ plus centers, rural, urban, all across the country. In a moment, I'll show you some questions that I asked to centers, and you can see that there are centers that responded here from California, Florida, Michigan. This will be a qualitative look at what it's like for LGBTQ plus CBOs on the ground during last year's MPOX outbreak. So we can go to the next slide. And you will see a number of quotes throughout this presentation. And while they're unattributed, they're direct quotes from LGBTQ plus centers and representative of multiple experiences. The questions that I asked through Centerlink, which is the organization of LGBTQ plus centers, were the following. How were you involved in MPOX vaccination efforts? What were the greatest challenges you faced? Did you experience vaccine hesitancy from the LGBTQ plus community? If so, what did that look like? And then what did you wish had been different? And what would you like to see done differently in the future? All right, next slide. So the responses to the first question fell into three categories. First was education, and a number of organizations engaged in education through town halls, and those were both virtual and in person, often in partnership with public health departments, other CBOs, health systems, etc. Additionally, LGBTQ plus CBOs created culturally appropriate materials focused on destigmatization, specifically with an awareness of what I call the echoes and shadows of the historical response to HIV crisis in the 80s and 90s. That's something we were up against the whole time. And then because LGBTQ plus orgs and people sit at the intersections of a lot of communities, which has already been mentioned today, we also focused on the creation of linguistically and regionally relevant materials. For Pacific Pride Foundation, that meant working on multilingual responses. For us, it's Spanish, it's English, and then it's also indigenous languages like Mixteco. The next slide, please. The second way that people responded was in terms of access. So people were involved through access by hosting and facilitating MPOX vaccine clinics, whether on their own or in partnership, and then integrating vaccination into ongoing activities. So a lot of us are doing, ongoing HIV or COVID clinics and just integrated MPOX vaccine right into those activities. And then because of the timing of this, many of our organizations were in the middle of Pride season. So for example, Pacific Pride Foundation has a Pride Festival in August. So we were able to integrate our vaccination efforts directly into our major Pride event. Next slide, please. And then third, the way organizations were involved was through coordination. So partnering with public health departments, other CBOs, health systems, local and affirming pharmacies. Often our organizations were first and fastest to respond to what's happening on the ground. We are trusted partners with community members. And for this reason, we ended up not only participating on regional MPOX task forces, but in some situations, actually creating those regional bodies. Next slide. Second question is, what were the greatest challenges that you faced? I found this quote especially illuminating, the sheer demand coupled with controlling the narrative, lack of funding, and ongoing work needs while responding to a crisis. I think a lot of us can understand what that feels like. Our organizations were already burdened by extended COVID response. Many of our organizations were in the middle of Pride season. We jumped in to advocate, stand up vaccine clinics, create coordinating bodies, many of us without our own health centers or clinical staff. We responded to community and media in the context of an incredibly tricky messaging challenge, given the historical governmental response to the HIV crisis. And there was a huge danger of stigmatization that we were up against. We're also providing ongoing services, oftentimes the only provider of those services in a given region, without any additional funding whatsoever. Next slide, please. Additional things that folks talked about with their organizations. Number one was vaccine access, quantity, and delay. I don't think that's a surprise to anybody. Supply issues, particularly at the beginning of the outbreak, led to frustrated community members traveling hours to find vaccination locations. Santa Barbara is a short hop from LA. We're just one county in between. We had folks driving to LA and calling us, finding out why they couldn't get it locally. Vaccination guidelines were confusing and challenging. Certain counties within a region had access to vaccines while others did not because, quote, there were not enough cases. I think we understood what was happening, but it was very frustrating to understand that, we needed to test positive in our counties when the county right next to us had cases and we could see it coming our way before we could get enough vaccine to start doing any good. And then guidelines were not always based in an understanding of the particular behaviors of the community. For example, the prioritization of those on PrEP, which is not an appropriate guideline for people who are HIV positive. Folks who are HIV positive were not prioritized because they couldn't be on PrEP, because you can't be on PrEP if you're HIV positive. Communication and coordination was another challenge. Coordinating with multiple health departments, lack of interdepartmental or cross-county coordination. For example, while larger county public health departments have CDC contacts, ours did not in Santa Barbara County. So that was leading to significant delays in securing special allocations for Pride events. There were just incredible communication challenges across the board, even with everyone doing their best. And then there was inconsistent prioritization at the local level. Next door in another county, folks were having a great experience. In the county beyond that, not such a great experience. There were just different prioritization levels happening at the county level. Next slide, please. So the question of whether or not vaccine hesitancy was something we saw on the ground, so across the board, it was a no. At Pacific Pride Foundation, we did not experience vaccine hesitancy. We had hundreds of inquiries regarding when and where people could get the vaccine. I will say that, as the previous speaker noted, there are issues around whether or not people experience discrimination once they access healthcare, but I don't think there was a question about whether or not folks were trying to access the vaccine. They were trying hard. They were driving for hours and waiting for days in lines. Santa Barbara County is, as I said, only 2 counties away from LA. It's a destination location. So people were wanting to receive the vaccine, but we only had 30 doses before having a confirmed case at the same time that LA was vaccinating thousands of people at Dodger Stadium. That was incredibly challenging. And people wanted the vaccine. Next slide, please. So what do folks wish had been different and what would they like to see different in the future? One is supply access, greater and faster vaccine availability. Again, I don't think a surprise to anybody. Guidelines that are more closely aligned with real-world understanding of the target population, an ability for CBOs to receive the vaccine directly instead of having to rely on local PhDs. Some of the organizations that had clinics wish that they could have received vaccine directly. Implementation of programmatic opportunities, funding. Funding or compensation for the expertise, partnership, outreach that was provided by CBOs and that's necessary for successful vaccination campaigns. That's something people would like to see. Better coordination with direct input into decision-making by CBOs and LGBTQ+ serving organizations on the ground and throughout. Streamlined and standardized communication between stakeholders, whether that's public health departments, CBOs, or federal partners. Regional coordination, providing vaccine by region as opposed to county where that's appropriate. There are places where that seems appropriate because the region is really what matters versus the county. And then on the data front, the collection of SOGI data is a critical step in systematically documenting and addressing health disparities affecting LGBTQ+ persons. We simply do not have enough comprehensive and disaggregated data regarding the LGBTQ+ community ever. Some more of that, please. Next slide, please. So the requests that we have are for formalized recommendations around these areas. For funding, to allocate and advocate for funding for CBOs that are providing expertise on the ground coordination, outreach, and implementation during the health crisis. Coordination, we'd like to see the creation of a structure that allows for both ongoing coordination of CBOs to problem solve at a peer level, as well as embedding further CBO representation into advisory bodies, and then creating CDC liaisons for CBOs directly. Next slide. On the access front, we'd like to see working with LGBTQ+ community health leaders to craft implementation plan that is based in understanding of the community and its particular behaviors, and prioritization of populations who need vaccine most from the beginning, and prioritize getting vaccine to the specific partners who serve those populations. And then on the data front, collecting sexual orientation and gender identity data throughout the duration of any outbreak, and releasing clear and consistent data so that everyone throughout the U.S. is able to understand an outbreak and make informed decisions on how to protect themselves. All right, next slide. And finally, a thank you. Thank you for having us. Thank you for including us. We appreciate it, and we'd like to continue the conversation.
Thank you very much, Kristen. Very nice presentation. Our next presenter is Dr. Henry Negg. Dr. Negg, your slides are up. You have the floor.
Thank you, everybody. My name is Henry Ng. My pronouns are he and they, and I'm really excited and honored to be part of this conversation today also. I'll be speaking a bit about HPV vaccination in LGBTQ+ communities. I serve as the director for the Center for LGBTQ+ Care, as well as the Transgender Surgery and Medicine program at the Cleveland Clinic, and I'm clinically trained as a med-peds physician, both in internal medicine and pediatrics. The next slide, please. So you've heard from a number of the speakers before me that we have a lot of opportunities to increase vaccination for LGBTQ people for many different reasons that I'll highlight in a few slides. But certainly there is data that describes and documents low HPV vaccination uptake in our sexual and gender minority adolescents and adults. Analysis of the GUT study, the Growing Up Today study from 1996 to 2014 demonstrates this. This was a prospective cohort of over 10,000 men and women, and adolescent boys and girls in the United States who were followed between 1996 and 2014. The participants were 18 to 24 years of age when the vaccine was first approved for females in 2006, and they were 14 to 27 years of age when approval for males was obtained in 2009. So in addition to reporting sexual orientation, identity, attractions, participants also reported sex of their lifetime partners in terms of identifying their sexual orientation and gender identity status. So there were log binomial models that were used to examine HPV vaccination across all of these sexual orientation groups. And what was found was among females, 56% had received one or more doses of HPV vaccine, but in contrast, 8% of males obtained 1% or more, or rather one dose or more of HPV vaccination. And HPV vaccine initiation was especially low among people who identified as completely heterosexual and male. After adjusting for a variety of confounders, it was found that completely heterosexual and mostly heterosexual identified males were half as likely to have received even a single dose of vaccine compared to gay males. So it's interesting that there are significant variations of vaccines within the sexual and gender minority communities. And then finally, looking at people who identify as lesbians, there are no specific differences that were observed between completely heterosexual or bisexual females, but mostly heterosexual females were 20% more likely to have received at least one dose. Next slide, please. So I want to speak to some of the practical strategies that I think exist to improve and increase HPV vaccination. And frankly, this can be applied, I think, to other vaccines as well. And you've heard from the other speakers about some of these challenges that we have barriers to care, including social determinants of health. These things include having insufficient insurance, being underinsured or uninsured, improving vaccine access at a variety of geographic sites, not just in clinics and hospital systems, but federally qualified health centers, community-based organizations, retail pharmacies, pop-up clinics, health fairs, and other settings. And frankly, also really improving psychological safety. When we're talking about patients who have been historically under-resourced and have experienced systemic and institutional discrimination, they may defer or avoid care services, including vaccination. So creating welcoming environments of care can go a long way in helping these patients in this community engage and remain connected to care. Strategies like offering vaccinations with other services, such as gender affirmation hormonal therapy, what the community is often called hormone replacement therapy for transgender people who are undergoing transition, or HIV pre-exposure prophylaxis, HIV prevention with medications, can make vaccination more convenient for our patients and community members. Finally, community involvement and presence in community can engender trust with caregivers and healthcare systems. So I'll now touch briefly on each of these strategies in the following slides. Next slide, please. So this is an image of our Lakewood Family Health Center, where normally I will be at. I'm actually at a different location today because I'm working with our resident team in precepting. But this is an image of our Family Health Center in the city of Lakewood. I want to just tell you a little bit about the community that we serve, and I think that'll help inform part of this discussion, give greater context. The city of Lakewood intentionally fosters an inclusive atmosphere for sexual and gender minority people. The city was established in 1889 with its 50,000 plus residents, making it the third largest city in Cuyahoga County, as well as the densest city in Ohio. We are a young city with our median age about 34 years. Our median household income is $54,000. Over 94% of our residents hold a high school degree. Almost 50% hold a bachelor's or higher degree. We are a walking community and we cherish our small businesses and community feel. The Family Health Center, which is depicted in this slide, was built in 2018 with the support of the Lakewood community and surrounding community and organizations. We see over 82,000 annual visits. We employ over 200 caregivers, including 62 physicians and APPs, 23 in specialty care. Our services include a 24-hour emergency room, outpatient radiology, and laboratory studies, lab services. We support medical education for medical students, internal medicine and family medicine residents, and many other learners. Our primary care services focuses on all age of life and creates a safe atmosphere for every person. We house the Center for LGBTQ+ care with primary and specialty care providers, as well as a transgender surgery and medicine program for the treatment clinic. Next slide, please. So in order to meet our patients' needs, we really try to follow the tenets and principles of justice, equity, diversity, and inclusion. We also encourage practicing respectful inquiry, meaning that we wish to know about our patients' experiences and values when recognizing and suspending while recognizing and suspending our own biases, as we get to know who they are, their lived experiences, and their concerns. In our medical home model, we have a team of affirming interprofessional caregivers who are knowledgeable about the health concerns and health disparities faced by our patients from our community. We support patients through primary care, gender affirmation hormonal therapy, HIV treatment, as well as HIV pre-exposure prophylaxis. Next slide, please. Knowing that barriers to successful vaccination include vaccine availability and convenience, our Family Health Center stocks a variety of vaccines for patients, including HPV, COVID-19, influenza, hepatitis A and B, meningococcal vaccine, pneumococcal vaccine, shingle vaccine, as well as Mpox. In 2022, Weldon identified some missed opportunities for HPV vaccination for men who have sex with men and transgender women who had presented for HIV PrEP. Nearly over 50% of study participants had previously not initiated HIV vaccination. Next slide, please. Recognizing this opportunity, at the Center for LGBTQ+ Care, we developed inclusive healthcare media for HPV vaccination. What's depicted on the slide is a flyer that we keep on our exam rooms to promote HPV vaccine as part of overall health promotion with the message, healthy people vaccinate. This was a product of an interprofessional student project that brought together medical, dental, social work, and nursing students to collaborate and devise a tool or intervention to help with a particular community. Our student group was interested in LGBTQ+ health and came up with the ideas which became this enduring health media. Next slide, please. Finally, presence in community can go a long way in engendering trust. The Lakewood Family Health Center and programs participated in a number of events this past year, including the ones that are here. And just to give you a little background of what you're seeing, you see me with my sassy fan and a number of our team members. These events included Pride in the CLE, which is Cleveland's annual LGBTQ Pride celebration. Thrive with Pride, an annual health fair during June, which is Pride Month, with STI testing, treatment, HPV vaccination offered during that session, as well as Lakewood Summer Meltdown, which is a popular summer festival in Lakewood and is actually held right in front of the Family Health Center where we are. And finally, we also had Akron Pride, which is one of our sibling cities in Northeast Ohio. These events create opportunities for outreach, health messaging, and rapport building. There may also be abilities to provide direct patient care. Our team was in contact with over 100 potential patients interested in care during these events over the summer. Over 20% of these individuals we contacted were ultimately linked to care with a new primary care provider. The strategies and steps that we took were instrumental, not just only for HPV vaccination, but with our outreach activities for MPOX as well as COVID-19 in 2022. Next slide, please. So here I provided a slide with the references for the topics I mentioned during our slide. And the next slide. Here's just a thank you for the opportunity to share our experiences and lessons learned in promoting HPV and other vaccinations and to LGBTQ communities, and to be able to be part of this really important conversation. Thank you so much for this opportunity, and please feel free to reach out to me in our program with any questions.
Thank you very much, Henry. Nice presentation. Our next presenter in this panel is Christina Graham. Christina, your slides are up. You have the floor.
Hello, and thank you for having me. I'd like to give a special thanks to Jen for really prepping us for much of what I'm going to share. I'm Christina Graham. I use she, her pronouns, and I'm the Data and Evaluation Manager at Bradbury Sullivan LGBT Community Center in Allentown, Pennsylvania. And today I'm going to be sharing with you a little bit about how we utilize that Pennsylvania LGBTQ health needs assessment to support the health education campaigns and services that we provide to our local community. Next slide, please. So, reiterating some of the points that Jen made earlier in this presentation, we found that many members of our community don't have a primary care provider to seek care from, and those that do may fear seeking care due to either past or potential negative reactions from healthcare providers when they disclose their LGBTQ identity. We see concerns about providers' competency in LGBTQ health issues, and there's also issues with availability and accessibility of affirming providers, especially in the more rural areas of our state. Next slide, please. So one of the earliest health campaigns that involved vaccination that Bradbury Sullivan did, and actually predates my joining the team, is this really fun campaign that we called If You Like the Taste of Peaches, promoting hepatitis A vaccination, both at our center in Allentown and as well as at local Pride celebrations in 2019. The most recently available data I have to give you a direct comparison was that in our 2020 health needs assessment, we found that 65% of LGBTQ Pennsylvanians were either not vaccinated or, as Jen said, unsure of their vaccination status. That has dropped a little bit with our most recent data from 2022. So this campaign was promoted broadly on social media, at events at the center, and as I said, at local Pride celebrations, really with the goal to increase hepatitis A vaccination among gay and bisexual men and transgender women living in Lehigh and Northampton counties in Pennsylvania. I really would say that the most important successes of this early campaign was making vaccination and important health information accessible and doing so in an affirming way. It also started to lay the foundation for some of our more recent campaigns, and we're actually hoping to return to Hep A vaccination perhaps in the coming year and revisit this work and see if we can continue to make an impact on this one specifically. Some really fun elements of this campaign was that a local drag performer dressed up as Princess Peach, like from the Mario Brothers franchise, to talk to people at Pride, just trying to make the health services that we provide a little bit more fun, a little bit more celebratory than perhaps people would consider. This campaign was also sponsored by Grindr for Equality. Next slide, please. So moving on from there, we've done quite a bit of work that certainly couldn't be fit into such a short time frame, including work on flu vaccination, referring people for Mpox vaccination, and a few others. But really one of the biggest ones that I wanted to share, considering that it's so timely, was the work we've done sharing COVID-19 safety information as well as vaccine information. With the health needs assessment being a biennial survey, the 2020 data was collected right after lockdowns began in Pennsylvania, meaning that Jen's team, when formulating the survey questions, did not have time to ask about experiences with COVID, and COVID vaccination was not yet available. So in that interim year, 2021, Bradbury Sullivan did an unfunded survey using much of the same network that we build to distribute the health needs assessment. And some of the findings were that we found that just under half of our respondents reported not being vaccinated at that time. Data was collected March and April of 2021. A concerning number of the participants in the survey, about 40%, did not know where to get a vaccine at the time they took the survey, and 46% had not yet contacted anyone for information on the vaccine or how to make an appointment. Luckily, we've seen that some of those barriers and other barriers that we saw at that time were concerns about cost, which was not something people need to be concerned with, but they didn't have the information to know that, wondering how they would get to appointments, and concerns about managing side effects if they weren't able to take off work have really started to drop off. Our 2022 data shows that those are among the lowest concerns, and that an overwhelming majority of LGBTQ Pennsylvanians have been vaccinated, with only about 4% having not received any level of vaccination. Here's an example of some of the campaign materials that we shared primarily online, as we felt that was the best way to reach people during the time that our center was not open, and being sure to be consistently sharing accurate and timely information with our local community. Much like in some of our previous work, we engaged local drag performers, but also community leaders and members of our staff to share testimonials about the vaccine or being vaccinated, so that we could give our community a sense of what they would experience when being vaccinated. And we found that promoting vaccination at our center allowed people to receive a service that they were somewhat concerned about in an environment that was safe and affirming. One of the major successes of this campaign, apart from high vaccination rates, was also mobilizing other local LGBTQ community-based organizations, starting in our local area, but then we provided technical assistance to centers as far away as Vermont in how to provide a safe space for community clinics and how to connect with their either regional healthcare provider or health department. Next slide, please. We're currently revamping our campaign about HPV as well as cervical PAPs. But findings from our previous health needs assessment again showed that a concerning number of our local LGBTQ community has not received appropriate vaccination. In 2018, nearly 80%, and this is only for those whom this vaccine and or service would be recommended, had not received vaccination, and about 1 in 3 had never had a cervical PAP. But then we see that dropping a little bit over time. And I think this is one of those things that is twofold. Not only are we providing educational information to our local community, but we also provide training for our local healthcare providers, how they can be better asking about the services that people need and how to talk about them in an affirming way. We've continued to do this campaign over time, and something that we've added to it is being able to provide the list of providers in our local area who've received training from us. Definitely, there's major success here in increasing awareness of vaccination and as well as important healthcare screenings. We find overwhelmingly in the health needs assessment that many of our respondents are not accessing critical screenings that protect their health. And the HPV and PAP campaigns are sponsored by some local organizations, including our local Planned Parenthood, and a fundraiser called the Women's 5K Classic. Next slide, please. I just wanted to take a few moments to talk about what this work looks like for me. At a community-based organization, I'm not a healthcare provider. I don't work for a healthcare organization, and I'm not even someone like Jen, who is primarily working in the public health data world. So our work involves this really complex data and evidence-based thinking, but also translating that into a way that's actionable for our community. There's also these links to these two reports. I'd love if you read them, especially our brand new 2022 Pennsylvania LGBTQ Health Needs Assessment. That report serves, and that data set serves as the foundation for all the work Bradbury Sullivan will do for the next 2 years until we have the 2024 data. So not just our health campaigns, but the youth programming we provide. We've recently increased the services that we provide on PrEP. We've always done HIV testing, but now we have partnered with a local organization that is providing PrEP prescriptions out of our center several days a month, including tomorrow, which I'm very excited about. So being part of a community-based organization means both thinking like a public health practitioner, but also really understanding the needs of our community. We heard from folks that our services weren't always accessible because of the times we were open. Now we have things on Saturdays. And I think that that's where the kind of thought that we need to be thinking of is, how do we go from this really great and really rich data to being able to say, this is how I provide services that a community needs. And since Jen was able to talk about the data so specifically and so wonderfully, and I really appreciate that, we can go to the next slide, which has my contact information. If you are interested in the Health Needs Assessment Report and hearing more about it and hearing more about how we use this data, we have a health summit coming up. It'll be 4 events, one each month, March, April, May, and in June, we're going to be talking about a variety of the health topics from the assessment, including social determinants of health, how we've leveraged this for other culturally responsive campaigns, and not just ours, but other organizations, mental health, and then we'll be wrapping up with support for tobacco-free spaces for Pride Month. And thank you so much for having me. I really appreciate it.
Thank you, Christina. I appreciate your presentation and that of the other members of this panel. Some really thought-provoking presentations from a lot of areas around our country trying to improve the health of our LGBTQI plus communities. Are there any questions or comments from the members of the committee or our liaisons and ex officios? If you would, please raise your hand or send me a note in the chat. Tim Cook has his hand up. Tim, go ahead.
Yeah, thanks for the excellent presentations. I had a question about the Mpox vaccine. So maybe for you, Kristen Flickinger. I just kind of wondered about what supply and demand would be like going forward. You know, obviously the outbreak came and went, thank goodness. I don't know if it's expected to come back, but I wondered whether you think there's an ongoing demand for the vaccine, even though the outbreak has died down. Is there any demand during this inter-epidemic period? I hope it's not but if it comes back, I just kind of wondered and where if there is demand, where would the supply come from? Obviously, it came from the strategic national stockpiles because the vaccine's effective against smallpox as well as Mpox. But I don't know if there's demand, should this be, or is it thought that this would be a commercial market? And that's probably more for FDA, CDC, and the companies to decide. But is like COVID switching from all government purchase to commercial? And so I didn't know what the situation is with MPACs, but is there demand, do you think, still?
Yeah, good question. And I think what I can do is I can answer anecdotally on the demand side. What I would say is we were seeing folks calling our office consistently, even after things were slowing down, right? After it looked like the outbreak was kind of under control, we continued to receive questions, especially about the second round vaccination. And it was very hard for folks to get the vaccine. So I can say locally for us, what was happening is people were calling us and saying, where can I get my second dose? And then we would call the county, and the county would say, they can call and go through kind of the guideline screening, or they can go to their doc, they can go to the primary care physician. We'd send them to primary care physician. Primary care physician would say, you don't qualify, or you don't need it, or it's slowing down. And it was just this runaround situation. So in terms of demand side, I know that we were getting calls in our office consistently for a while, even as things were slowing down. What I think is a more important kind of conversation moving forward is, what do we do next time when it's not MPOX? I can tell you what happened on the ground. I'm not an epidemiologist. I'm not, I'm a community-based organization executive director. What I'm interested in is, how do we make sure that next time when something pops up, that we are ready to get it out to the folks who are on the ground, connected to the community as quickly as possible, so we don't have hundreds of people calling with nowhere to go.
Yeah.
I don't know if that's helpful.
Yeah, it is. Thank you.
Thank you.
Next question is from Jewel Mullet.
Good afternoon, and thank you for all of the rich presentations. Listening to them, I wonder whether or not there's anything else that we can learn or that you're doing to help us better understand specifics. If your data were stratified more by age, I'm interested, for example, in older adults and pneumococcal vaccine, influenza vaccine, zoster, and other things that we might be thinking about to make sure there's real equity and access there. And also just a number of other intersectionalities, including race and ethnicity.
If that question's open for anyone to answer, I'd love to jump in, and perhaps Jen can supply anything I've missed. One of the fantastic things about the data set we use is that it's incredibly rich. The 2022 data had more than 4,200 respondents. The 2020 data set has more than 6,500 respondents, going from 13 to into their 90s. I presented to Pennsylvania's Department of Aging in October, and we found, unfortunately, we don't ask questions about shingles or the pneumonia vaccine, but we found that overwhelmingly, and I'm so positive about saying this, it was really a wonderful finding, that our community elders are, at least in our area, doing pretty well as far as healthcare access. The thing that they're really missing is that across the entire community, there's concerns about depression and loneliness, but they are the most likely to have a primary care provider, to be insured, to be seeing a provider regularly, and to be receiving important screenings, especially those that are typically recommended based on age. There's good access to things like colonoscopies. So my guess would be that at least for those members of our community, they're also accessing things like their their pneumonia vaccine, because it's recommended by age, and they likely have a primary care provider that they've been seeing for some time. I would definitely be concerned about some of our community members that are perhaps receiving those recommendations for other reasons. Diabetics are often recommended to receive the pneumonia vaccine, but we find low rates of diabetic screening in many areas of our state. We did look at especially when we were looking about the community opinions about the COVID-19 vaccine when it was first becoming available, that our transgender community members were not accessing it at the same rates as their cisgender peers, as well as concerns about communities of color, especially in the more rural areas of our state. But that does seem to have picked up. But it is something that we continue to monitor because we know that there's concerns about access, including that affirming providers may be too far away. Jen, I don't know if you want to add anything to that.
Thank you.
Yeah, if not, Jen, I'd love to jump on a soapbox, if that's okay, about disaggregated data. So I think it's a really important question about how, like, what would we do with better data if we had it? You know, as someone, again, not an epidemiologist, not a researcher, just someone who's tried to use data to prove the importance of programming, specifically as it relates to LGBTQ women, non-binary, trans folks. We don't have good data. We're starting to have good data because we're now collecting our own data, but you know, the only longitudinal data that exists out there for our community is around HIV and men who have sex with men, to my knowledge, right? So there are parts of our community that are more easily erased, whether that's the bi community, non-binary, trans community, older adults, youth. And when we don't have good data for those parts of the community, it's very hard to prove that we need more funding to provide more services or more funding for anything regarding these communities. So the more data that we can have, the more standardization we can have to get the disaggregated data, the better we will be able to advocate for, fund, and then provide services for all the parts of our community, especially those who are most vulnerable, in my opinion.
John Dunn, do you have your next hand up?
Thank you. It's actually, you guys, with your extensive answers to these other ones, you've actually answered much of what I had to ask. I really appreciate all of these talks. This is particularly vexing. We had a subcommittee on vaccine confidence that recently wrapped up work. And one of the things that was a particular challenge for us was that there was remarkably little good data on that in this particular population, and so this has been very helpful and informative. It points out an interesting challenge, which is that in this case the confidence lies less with the population than with the source of the information. Although I think that's true for a lot of subpopulations. That is to say, these, by and large, these people who are willing to do what they need to do for their health, get vaccinated, etc. But that message needs to really come from the right place. And consistently, as you brought up, that right place are organizations that they trust, that are safe spaces, where they feel as though they're getting proper direction. Any thoughts beyond what you've already expressed about whether there's anything larger scale, more programmatically, something else that can help to make messages from a broader scope more trusted to LGBTQ populations about vaccination?
I'm talking a lot. I'm going to jump in again then. Involvement of LGBTQ plus organizations and people visibly from the beginning. It's important to have clinical folks around the table, but also non-clinical folks who are just part of the community and embedded in an authentic way. That's how you build legitimacy and buy-in from the community, and we're happy to help with that.
Great, thank you very much.
I'm just going to echo what Kristen said about, you said the word visual, and that really triggered something for me. We ask a qualitative, open-ended question in the health needs assessment. What would you tell your provider to be more welcoming? People need visual cues that they are welcome. So health campaign materials that represent a wider range of identities. You don't always have to say it with words that we're thinking of you too.
And this is Jen Keith. I'll just put one more plug in here to get the data in the hands of many people. So we're probably representing many different states on this meeting today. If you visit your BRFSS data for your state, check and see if they have the SOGI data questions. That just makes data accessible to community-based organizations, researchers, students, anyone who wants to do a crosstab to have a better understanding. When states don't include those questions, that invisibility comes right back. So just in thinking about so many folks who may have great ideas, we have to get them those data. So BRFSS could be a good place to start if your state hasn't yet included or made those data publicly available. Thank you.
And Bob, Dr. Ning would like to make a comment too.
Thanks, Ann. You just beat me to it. Henry Ng, please go ahead.
Yes, thank you. And this is, I think, part in response to John Dunn and to Joe Mullins, that I think that on the implementation program development side, some of our challenges, again, also come back to data. So healthcare organizations have complicated health informatics structures where identifying sexual and gender minority patients in kind of a thoughtful, comprehensive way, while also recognizing that not everyone wants to be identified, is a challenge in figuring out, well, how many people actually are the group that you're caring for, what are their concerns and their disparities. So this is an ongoing challenge of developing patient care registries to know who you're serving so that you can have, frankly, the epidemiological data of the receipts and be able to see the effectiveness of the programs that you're creating. I know we're struggling with this here at the Cleveland Clinic, and we have a lot of resources at our disposal, and we just have been successful in developing a dashboard to identify and look at our transgender non-binary patients, and I'm working to create one that's a bit more comprehensive to identify and know who our sexual and gender minority people are more broadly. And that way we can actually look at some of the population health concerns, whether these are ACO metrics or things related to specific vaccinations. And then we can also drill down on intersectionality.
Great. Thank you. And again, thank you all. This was a really wonderful panel. I appreciate all your work.
Any final questions or comments? Hearing none, I do want to once again thank the members of this panel. Very good information across many different areas in our country, and a population that unfortunately has really been disenfranchised far too much in the past, and I appreciate your engagement. At this time, we're going to turn to our next panel. Our next panel is COVID-19 Vaccine Safety Data Review. I'll be providing the initial presentation, followed by Dr. Ian Krasalik from the Centers for Disease Control and Prevention. And we'll also have Dr. Matt Oster, who's from CDC. He's a pediatric cardiologist, subject matter expert, and Dr. Tom Shimabukuro, who's the lead of the Vaccine Safety Office at CDC, that will be on to help us if there are questions. In this panel, Dr. Krasalik and I will provide presentations on COVID-19 vaccine safety. I'm going to provide a safety assessment from the COVID-19 Vaccine Safety Technical Subgroup, or VAST, and Dr. Krasalik will present on some outcomes of myocarditis after mRNA COVID-19 vaccination. And if we'll go to my slide set, please. Putting on my other hat, thank you all for the opportunity to speak to you about our work in VAST. I have been honored to work with this committee with the Kip Talbot, who's the VAST chair. If we'll go to the next slide, please. The VAST committee was put together back in December of 2020 with the objectives of reviewing, evaluating, and interpret post-authorization and approval COVID-19 vaccine safety data to serve as a central hub for technical subject matter expertise from federal agencies conducting post-authorization and approval safety monitoring, to advise on analyses, interpretation, and presentation of this data, and to provide updates going forward. Next slide, please. We continue to review COVID-19 vaccine safety data from the passive and active surveillance systems. as listed here on the slide, and also have received input from international partners, including Public Health Agency of Canada and the Global Advisory Committee on Vaccine Safety, and have also had a number of discussions about special evaluations, including myocarditis follow-up. Next slide, please. From December 21st, 2020 to the end of January, we've had 70 independent meetings to review vaccine safety data. We've had 17 joint meetings with the ACIP COVID-19 Vaccines Work Group, and there have been 21 ACIP meeting presentations or reports, including our VAST assessments. Next slide, please. The CDC's ACIP has really only had one major COVID-19 vaccine action since I last presented to you in September of 22. On October 22nd, ACIP recommends addition of the COVID-19 vaccines to the VFC program for all children 6 months to 18 years of age. But that action is really only a future action at present. At the present time, COVID-19 vaccines remain available to all Americans under the current U.S. government national COVID-19 pandemic response. And once COVID-19 vaccines are available in the commercial market and no longer under the COVID-19 response, VFC providers will be able to order them through the VFC program. And again, that timeline has not yet been determined. Next slide, please. So VAST assessment updates since October. There was a summarized data on the safety of mRNA primary series and boosters presented to ACIP on October 22nd. And on January 26th, some COVID-19 messenger RNA bivalent booster vaccine safety data was presented to VRBPAC in consideration of future COVID-19 vaccine regimens. Next slide, please. And this again is a reminder of the active surveillance, passive surveillance, individual case consults and clinical research, as well as the large database surveillance programs that have been the primary sources of data that we've looked at in our VAST committee. And I really appreciate all the hard work from many, many dedicated individuals across the vaccine safety system that have helped us in our work. Next slide, please. Again, our VAST reviews have been a component of the ACIP assessment of risk and benefit of COVID-19 vaccines. And you'll go to the next slide, please. So to summarize the mRNA COVID-19 vaccine safety of primary series vaccination in children ages 6 months to 5 years, this was presented to ACIP both September 1st and October 22nd of 22. The initial safety findings of both the mRNA COVID-19 vaccines from Pfizer, BioNTech, and Moderna are consistent with those observed in clinical trials. The systemic and local reactions are commonly reported as adverse events, and vaccination errors are also being reported commonly to VAERS. There were no unexpected safety findings to that point, and that remains true, and no evidence of increased risk for myocarditis was found following mRNA COVID-19 vaccination in children aged 6 months to 5 years. If you'll go to the next slide, please. This shows the VAERS reporting rates for verified myocarditis per million COVID-19 vaccinations, combining both the messenger RNA vaccines in the first 7 days following vaccination. The highest rates were following dose 2, and there were episodes of myocarditis primarily in male patients following the first booster dose. Next slide, please. And this is the VSD incidence rates for verified myocarditis and pericarditis in the 7 days after the Pfizer vaccination in persons aged 5 to 39 for dose 2 in the first booster. Again, we've seen these slides back at our last meeting. Next slide, please. So to summarize the COVID-19 vaccine safety of booster doses in persons aged 5 and older, the safety findings are generally consistent with those observed for primary series. The evidence does suggest an increased risk for myocarditis following the first booster dose, noting that myocarditis is a rare event following mRNA COVID-19 booster vaccination. At the time of this presentation, CDC had verified 131 myocarditis case reports in VAERS in persons aged 5 and older, after over 123 million messenger RNA COVID-19 booster vaccinations. The risk was primarily observed in adolescents and young adults, and there was no statistical signal for myocarditis in children ages 5 to 11 following the first booster. In the VAERS data, the reporting case rates for myocarditis were lower following the first booster than after the second dose in the primary series, and the second dose in the primary series rates were higher than following the first dose. In the VSD analysis, myocarditis, pericarditis incidents following the first booster dose and dose 2 were similar, although case counts were small and the confidence intervals around these estimates are wide. Next slide, please. So the next topic that we looked at was COVID-19 messenger RNA bivalent booster safety. There was a detailed presentation to VRBPAC by Dr. Shimabukuro and Klein on January 26th. For background, the bivalent boosters were first available in the U.S. in September of 22, and as of January 11th of this year, almost 50 million COVID-19 mRNA bivalent booster doses have been administered in persons 5 and older, including about 21.3 million doses in persons aged 65 and older. And the CDC and partners continue to monitor the safety of licensed and authorized vaccines using these multiple systems. And the safety data continue to support CDC's recommendations that everyone eligible for a bivalent booster should be vaccinated. Next slide, please. The VSD has continued to perform rapid cycle analyses for COVID-19 vaccines, and this includes the bivalent boosters. They've looked at these for a pre-specified set of outcomes assessed during weekly sequential monitoring following the bivalent booster vaccination, looking at the risk for pre-specified outcomes in the 1 to 21 days following the bivalent vaccination, comparing with bivalent vaccinated individuals at 22 to 42 days following that dose of the bivalent vaccine. And these analyses are all adjusted for age, sex, race and ethnicity, VSD site, calendar days, and seasonality, and a signal was defined if the p-value is less than 0.01 on a one-sided test. Next slide, please. There was a signal detected for the Pfizer vaccine in persons aged 65 and older for ischemic stroke. There were 130 risk events as compared to 92 in the comparison time interval, which did meet the signal definition. Next slide, please. In looking at this sequentially week over week, we see that the relative risk of these events was higher earlier on, and that seems to have attenuated. This is showing data from October 16th through January 8th. Next slide, please. And this looks at the clustering of those events. There appears to be a significant cluster at days 11 to 22 following the Pfizer bivalent boosters in people aged 65 and older. Next slide, please. So the VSD team summarized as follows. This statistical signal has persisted for 7 weeks. The rate ratio has slowly attenuated from initially around 1.9 to 1.47, but has continued to meet signaling criteria. They've done some additional signal investigation analyses, the temporal clustering that I showed you on the previous slide. There have been supplemental analyses using unboosted concurrent comparators showing a rate ratio of about 1.07. They've looked at a small subset of charts, and most confirmed cases had co-administration of high-dose or adjuvanted influenza vaccine. And the analyses evaluating those that got concomitant high-dose or adjuvanted flu vaccine show a rate ratio of 2. But separate analyses didn't detect an elevated rate ratio for stroke after flu vaccine alone. Supplemental analyses also suggest the comparison interval at 22 to 42 days after vaccination showed rates of ischemic stroke which were lower than expected. Next slide, please. There were a small number of strokes, and the rate ratios are imprecise, which does limit some of the analyses. There was a reduced follow-up time following Moderna booster because there were some initial distribution delays of the Moderna bivalent booster. The concomitant flu vaccine analysis was limited by small numbers. It's difficult to interpret the temporal clustering during the risk and comparison intervals, and there may be unmeasured confounding. such as the results may be influenced by confounders that vary over time. It's also possible that early adopters of bivalent booster vaccine may have a greater risk of near-term cardiovascular events, although that trend has not been observed for acute myocardial infarcts. And there's the potential of differential vaccine availability that affected some of these data, as the Pfizer bivalent vaccine was available well prior to the Moderna vaccine. There's also a possible role of SARS-CoV-2 infection before the booster. The background incidence of SARS-CoV-2 infection was rapidly changing during the time of bivalent booster uptake. The analyses did exclude cases where COVID-19 diagnosis or a positive test was documented in the chart in the prior 30 days, but asymptomatic infection and home antigen tests were not consistently documented in the EMR. Although the folks in the study sites didn't find recent SARS-CoV-2 infection or exposure. Next slide, please. This is some data from VAERS looking at reports of ischemic stroke and TIA after bivalent COVID-19 mRNA vaccine. The panels show the rates for Pfizer-BioNTech and Moderna vaccines separately, chart verified reports to the left, and chart verification reports under review to the right. The reporting rate among persons aged over 50 years per million doses are shown in the chart. The chart verified reports are about 1.1 ischemic stroke per million doses of Pfizer-BioNTech, and the same for Moderna. Including reports under review, that's about 2.3 per million doses of Pfizer-BioNTech and 2.1 per million doses of Moderna. And the incidence of ischemic stroke in historical studies among ages 65 and older is between 670 and 970 per 100,000 person years, far higher than the reporting rate seen in VAERS. Next slide, please. This is a summary slide from a presentation from Dr. Rich Foshi from the FDA, also presented at VRPAC last week. The data suggesting an absence of a safety risk for the bivalent boosters in those aged 65 and older. First being the lack of excess reports of stroke from VAERS, as I showed you in the previous slide. The CMS database was queried looking at about 4.25 million doses, shows no increase in stroke. The VA database shows no increase in stroke on a preliminary query. And a number of countries in Europe, as well as Israel, indicate no increased risk of stroke in their surveillance systems. And then Pfizer has noted no increase in signal in their global safety database or when comparing the monovalent to bivalent vaccines. Regardless, FDA has begun a formal epidemiologic study to prepare for potential further vaccine co-administration in the future. And I've got your reference to his presentation below. Next slide, please. So our vast assessment is that the statistical signal among persons aged 65 and older for ischemic stroke and TIA following the bivalent Pfizer-BioNTech COVID-19 booster in VSD shows a slightly elevated rate ratio, which just exceeds statistical significance and has been attenuating over time. Other vaccine safety monitoring systems in the United States and internationally have not observed a similar signal, and that VAST will continue to review data from additional analyses planned from VSD, from CMS, and the VA. Next slide, please. So what are the next steps for VAST? Well, we will continue to review data from national safety monitoring systems and manufacturer post-marketing requirements for the COVID-19 vaccines. Real-time monitoring for vaccine safety as vaccination efforts continue to expand. We'll continue to collaborate across U.S. federal agencies evaluating vaccine safety and with global vaccine safety colleagues on key issues that impact benefit-risk balance. And we'll continue to provide updates to the COVID-19 vaccine work group, ACIP, and NVAC going forward. VAST will be transitioning our ongoing safety assessment of COVID-19 vaccines to the COVID-19 vaccine work group in coming months. Next slide, please. And this is my final slide, and I use it to acknowledge our appreciation for Laurie Markowitz and Melinda Wharton, our CDC co-leads, for Jared Wu, who's provided administrative support, the ex officio and liaison representatives, and the members of our VAST committee, including our committee chair, Dr. Talbot, and that ends my presentation. And we'll now go to the presentation slides for Dr. Krasalik. Dr. Krasalik, your slides are up and you have the floor.
All right, thank you. Good afternoon, and thank you for the invitation to speak with you today. Next slide, please. So just a standard disclaimer that the findings and conclusions of this presentation are my own, and the data are preliminary and subject to change. Next slide, please. So this talk has two main objectives. One is to describe CDC's enhanced surveillance of outcomes of myocarditis after mRNA COVID-19 vaccination. And two is to describe outcomes at least 1 year since the onset of myocarditis by providing preliminary findings from patient self-reported symptoms and quality of life measures, and also healthcare provider assessments of cardiac recovery status. Next slide, please. So I'll start with some background information on myocarditis after mRNA COVID-19 vaccination. Next slide, please. Here I will briefly describe how myocarditis after mRNA COVID-19 vaccination was identified. Myocarditis after mRNA COVID-19 vaccination was identified in Vaccine Adverse Event Reporting System, or VAERS, case reports. The findings from these VAERS reports was also supported by evidence from safety monitoring systems in multiple countries. Reports of myocarditis were then reviewed by physicians at CDC and by the Clinical Immunization Safety Assessment, or CISA, project investigators, who developed a case definition for myocarditis and adjudicated cases. Published data from Oster and others described approximately 1,600 reports of myocarditis from the US that met the CDC probable or confirmed case definition. Oster and others found that the rate of myocarditis was highest in adolescent and young adult males aged approximately 12 to 29 years, and found that most of those that were hospitalized had resolution of symptoms at discharge. However, less is known about longer-term outcomes. Next slide, please. So in order to look at these longer-term outcomes, surveillance was conducted to assess what we termed medium-term outcomes, at least 90 days since the onset of myocarditis after mRNA COVID-19 vaccination. Published findings from a follow-up of a cohort of 519 patients aged 12 to 29 years from the Oster and others study I described earlier suggested that about half of these patients self-reported experiencing at least one symptom of shortness of breath, chest pain, palpitations, or fatigue in the 2 weeks prior to the survey. And quality of life measures were comparable to US population estimates before and during the COVID-19 pandemic. And most had improvements in cardiac biomarker or cardiac imaging. However, about half had abnormal cardiac MRIs. To note, though, not everyone had a cardiac MRI. Healthcare providers considered most to have a recovered cardiac status. However, additional follow-up was needed for those patients not considered recovered to better understand their long-term outcomes. Next slide, please. So I'll describe some of the methods we used to conduct this longer-term follow-up. Next slide, please. So CDC conducted surveillance for myocarditis outcomes after mRNA COVID-19 vaccination at least 1 year since onset. The purpose of this was to assess functional status and clinical outcomes among individuals aged 12 to 29 years in the US that reported to have developed myocarditis after vaccination and who met the CDC probable or confirmed case definition. To do this, a two-component survey conducted at least 1 year since the onset of myocarditis symptoms for patients not considered fully or probably fully recovered by a healthcare provider at the time of the 90-day follow-up, as reported by Krasalik and others. The first part of the survey was a patient survey that ascertained functional status, clinical symptoms, quality of life, and current medications or other medical treatment. The second part was a healthcare provider survey that reported cardiac health and functional status, cardiac recovery status as determined by the provider, with the data collection during January 13th of 2022 to the present day. Next slide, please. Additionally, as an assessment tool, the EuroQol 5-dimension 5-level or 5D-5L measurement of patient health-related quality of life was used. The EuroQol questionnaire characterizes health across 5 dimensions, which include mobility, self-care, pain or discomfort, ability to perform usual activities, and anxiety or depression. 5 levels of severity are assessed across these dimensions, from no problems to extreme problems, that were dichotomized in this analysis as no problems or any problems. Patients also self-rated their overall health using the EuroQol Visual Analog Scale, or EQ-VAS, ranging from 0 to 100, with 100 representing the best possible health. Next slide, please. So next, I'll describe the preliminary data from the completed surveys of patients or their parents at least 1 year since the onset of myocarditis. Next slide, please. So this slide shows the flow chart of the data that were collected. As of September 2022, 134 patients, 12 to 29 years of age, were identified via healthcare provider surveys as not fully recovered from their myocarditis at the time of the 90-day survey, and who were at least 1 year post myocarditis onset. If we follow the diagram to the left for the patient or parent portion of the survey, we see that 60 patients completed a survey, and of those, 33 were unlinked, meaning they did not have a completed healthcare provider survey. If we go back up to the top and over to the right for the healthcare provider survey, we see that 63 healthcare providers completed a survey and conducted patient follow-up since the time of the last 90-day follow-up. Of these, 36 who were unlinked did not have a completed patient-parent survey. Overall, 27 linked surveys with both the patient and provider portions of the survey were completed, and in total, data were collected on 96 individuals. Next slide, please. So next we'll look at some results of the myocarditis from the patient portion of the survey. As I mentioned, as of September of 2022, there were 134 patients identified during the provider 90-day follow-up assessment who were not considered recovered from their myocarditis and were at least 1 year since onset of myocarditis. 65 patient calls were completed. 5 patients declined to be surveyed. 60 patient surveys were completed, and for those 60 patients interviewed, the median interval from myocarditis onset to the interview was 405 days, with an interquartile range of 383 to 420 days. Next slide, please. So this slide shows the demographics of patients who completed the 1 year survey. If we look at the graph below, we have sex and age group on the x-axis and the number of patients on the y-axis. Males are shown in the dark blue bars and females in the light green bars. The median patient age was 17 years with an interquartile range of 15 to 21 years. And of the 60 patients surveyed who were at least 1 year since myocarditis onset, 90% or 54 were male. Next slide, please. Here, this slide shows self-reported patient symptoms within 2 weeks prior to the date of the interview for the 1 year survey. There are 4 main symptom types on the y-axis: chest pain, shortness of breath, palpitations, and fatigue. The proportion that answered yes to experiencing each symptom type is shown in the dark purple bars and no in the yellow bars. The number of patients is shown on the x-axis and shows about a quarter of patients reported experiencing chest pain, while less than a fifth of patients reported experiencing shortness of breath, palpitations, or fatigue. Next slide, please. So this slide is showing a comparison of self-reported symptoms in the same patients within 2 weeks prior to the date of the interview for the 1 year and 90-day surveys. So we're still looking at the 4 main symptom types: chest pain, shortness of breath, palpitations, and fatigue. At the time of the 90-day follow-up, 68% of patients reported at least 1 symptom, while at the time of the 1 year survey, 33% reported at least 1 symptom. So we're seeing a reduction in the number of patients reporting at least 1 symptom. Next slide, please. Here, this slide shows the findings from the EuroQol measurement of patient health-related status at 1 year follow-up. In the graph below, the x-axis represents the 5 dimensions of health-related quality of life, including self-care, mobility, ability to perform usual activities, and pain and depression. The y-axis represents the number of patients. No problems are shown in blue, and any problems reported are shown in green. Most patients did not report problems for self-care, mobility, or ability to perform usual activities, although about a third reported problems with experiencing pain, and a little less than half reported problems with depression or anxiety. Next slide, please. So here we're showing the results of the EuroQol visual analog scale at 1 year follow-up. The respondents of this question had a median age of 19 years with an interquartile range of 16 to 23 years. For the box plot on the y-axis, the scale goes from 0, which represents the worst possible health imaginable, to 100, which represents the best possible health. Each dot represents a patient self-assessed score. The median score was 90 with an interquartile range of 80 to 95, suggesting overall good health, although there were some patients that reported low scores indicating they were currently in poor health. Next slide, please. Next, I'll report on preliminary data from completed cardiologist or other healthcare provider surveys at least 1 year since the onset of myocarditis. Next slide, please. So here are the results from the healthcare provider assessment of myocarditis patients. As mentioned previously, there were 134 patients identified. 105 healthcare provider surveys were completed. Of these, 63 had seen the patient for a follow-up visit since the last survey conducted at the 90-day follow-up. 34 or 54% of these providers were cardiologists. Of the 63 healthcare provider interviewed, the median interval from myocarditis onset to the last healthcare provider follow-up was 287 days, with an interquartile range of 237 to 356 days, and no patient deaths were identified in this group. Next slide, please. So this slide is showing clearance for physical activity in the same patients by their cardiologist or healthcare provider at the time of the 90-day and 1 year surveys. At the time of the 90-day follow-up, about half of patients were cleared for all levels of physical activity. And then at the time of the 1 year provider survey, 86% were cleared for all levels of physical activity. So greater rates of clearance for all physical activity over time is shown. Next slide, please. This slide shows the most recent cardiac tests since the 90-day survey for the 1 year follow-up cohort. So this includes any test performed after the 90-day follow-up was conducted. We have the type of tests performed on the x-axis and the number of patients on the y-axis. The dark blue colors represent normal or baseline results, and the green colors represent abnormal or elevated results. You can see that most test results for troponin, echocardiograms, electrocardiogram, exercise stress testing, and ambulatory rhythm monitoring were normal or baseline. However, slightly more than half of cardiac MRIs performed were abnormal. Next slide, please. This slide shows cardiologist or healthcare provider assessment of cardiac recovery status at the time of the one-year survey. The graph below shows the classes of cardiac recovery status on the x-axis and the number of patients on the y-axis. 37 or 59% of healthcare providers indicated patients had a fully or probably fully recovered cardiac status. 2 patients had the same status as at the time of the initial myocarditis diagnosis, and 2 patients had worsened. Of the 2 patients with a worsened status, one with underlying cardiac disease pre-myocarditis diagnosis was rehospitalized. Next slide, please. So there were some limitations to our surveillance. There's no standard level of care for myocarditis after mRNA COVID-19 vaccination, contributing to variability in provider practices and the types of follow-up testing that were performed. There was an absence of any control group to contextualize self-reports of ongoing patient symptoms. Additionally, patients were lost to follow-up, and there's the possibility of non-response bias. And lastly, the small sample size may limit the generalizability of our findings. Next slide, please. So to summarize, in patients not considered to have a cardiac recovery status at 90-day follow-up, most with a healthcare provider survey at the one-year time frame were considered to have fully or probably fully recovered cardiac status since the last healthcare provider follow-up. One patient who was considered to have a worsened cardiac status was readmitted to the hospital since the 90-day survey. There did not appear to be a single test that was indicative of recovery, and to our knowledge, there were no myocarditis deaths in this group. Looking at the findings from the 90-day and one-year surveys in totality, if we combine results from the 90-day and one-year survey, most patients were considered to have fully or probably fully recovered cardiac status. Next slide, please. And I'd like to thank all those involved with this project that made it possible. And next slide, please. And that ends my talk, and I'll be happy to take any questions.
Thank you, Ian. Are there any questions or comments from those on the call? Last call. John Dunn, I see your hand up.
Yeah, sure. This is just always so interesting for me to see, especially because I get asked about it constantly in my role here at home. It would be interesting to know, and I don't know if you guys were privy to any of this, whether the information that we've got on these adverse effects on sort of on how myocarditis is playing out or what's playing out with stroke, it'd be interesting to know how much impact that has on any given person deciding to get or not get vaccinated at this point. That is, I wonder if, for example, with the stroke risk, if the folks who've decided already to get vaccinated and have been getting vaccinated on schedule, as we've recommended, if they're at a point now where when they read this about stroke and they see, okay, we think it's this, it may not actually be a clinical concern. If they're relatively comfortable with that, and unless they receive marching orders otherwise, they will continue to proceed with getting vaccines. Whereas those who already don't, just plain don't. That is to say, I wonder now if the subset of people that still gets vaccinated, I wonder how much information like the new finding of stroke impacts their behavior. Do you guys have any idea? Was that discussed at all at ACIP or elsewhere?
I think that it's an open question, John. My anecdotal experience is very much like yours. People seem to have fallen into a camp of I'm going to be vaccinated, I'm willing to be reassured, or I'm not going to be vaccinated regardless of anything. I think this is fertile area for future research, but I have not seen any systematic evaluation to date.
Okay, thanks. Thanks, Bob. Thanks both of you for those presentations. Those were terrific. I always appreciate this part of the meeting.
Thanks. Any other questions or comments? And I also want to thank Matt Oster and Tom Shimabukuro for being on in the event there were questions. I hate that you came on without being asked questions, but that's a good thing also. All right, not seeing any other hands or comments in the chat. Let's move on to our next presentation. Our next presentation is the Vaccine Safety Subcommittee update. Rob Schechter, who is one of the co-chairs of our Vaccine Safety Subcommittee, will provide a brief update on the subcommittee activities. Rob, your slides are up. You have the floor.
Thank you, Bob. Good afternoon. On behalf of my co-chair, Stephen Rinderknecht, and the subcommittee would like to provide a brief update on our charge, our activities to date, and our plans for the near future ahead of a production of a report for the committee later in this year. Next slide, please. This is a list of our fantastic subcommittee members, feeling extremely fortunate, echoing Bob Swanson's comments yesterday about gratitude for the capability and talents of the subcommittee members and the dedication of the OIDP staff in supporting us through this process. Next slide, please. To briefly review the charge from Admiral Levine, that the subcommittee should review key documents, including the prior NVAC report on vaccine safety and relevant sections of the 21 to 2025 Vaccines National Strategic Plan, and outline opportunities for continual improvement of vaccine safety activities during vaccine development, licensure, and post-market use. Make recommendations to address current and emergent vaccine safety challenges, minimize preventable vaccine-related adverse events, and improve all the individual components needed for a strong safety system. Provide direction to improve coordination and stakeholder input into the timely detection and assessment of vaccine safety signals, such as the one we just heard about, to better inform clinical decision-making and public health policies. Describe science-based activities that HHS and federal partners can take to increase knowledge and use of the vaccine safety system, and to create a succinct report. Next slide, please. Along with those highlights, the charge includes topics for exploration on these next slides, including innovations to detect or investigate adverse events more quickly, ways to provide better data about underlying mechanisms of vaccine safety signals, new methods to prevent or capture administration errors, guidance on improving transparency, communication, and knowledge of the process of weighing risks and benefits for vaccination, approaches for improving timely access to vaccine safety data for researchers and analysts, and messaging strategies to support a more effective dialogue with healthcare professionals and patients. The remaining topics on the next slide include reviewing evidence-based practices that encourage reporting of suspected adverse reactions, including recommendations to reduce the vaccine safety burden on healthcare providers, methods to facilitate the timely exchange of vaccine safety information between federal, state, local, territorial, tribal authorities, and vaccine stakeholders, pathways for the development of data sources to improve analytical abilities, such as provide racial and ethnic breakdowns or increase our collective ability to detect safety signals, and investments in additional education and training for healthcare providers on the prevention and treatment of vaccine-related adverse events. Next slide, please. So to date, in response to the charge, the subcommittee has had 4 meetings, during which have reviewed those key documents identified by Admiral Levine, along with related NVAC recommendations. We've hosted expert speakers, including subcommittee members, on U.S. vaccine safety monitoring systems, safe medical practices in reporting and administration errors. And looking ahead to our next meetings, hope to hear from additional experts on international vaccine safety systems, Agency for Healthcare Review and Quality Systematic Review, recent review to look at that, and to review injury compensation programs. Next slide, please. After active discussion and proactive work by committee members, we have a draft outline of the report looking ahead to later this year that could include an introduction, consideration of pre-licensure factors and methods, methods for post-licensure vaccine safety monitoring, timely detection and assessment of vaccine safety signals. Next slide, please. Vaccine administration errors, considerations for public vaccine safety communication, and I think thinking carefully about the confidence report issued by Chair Dunn and colleagues over the last year, training future leaders, and overall recommendations. Next slide, please. The topic open for discussion, and certainly welcome your input both in the next minutes and in the weeks ahead as the subcommittee proceeds in its charge.
Thank you very much, Rob. Are there any questions or comments from those on the call? If you would, please either raise your hand or send me a note on chat. David Fleming.
Yes, hi. I have a bandwidth issue, so I'm going to keep my video off. Thanks for that presentation. I'm wondering if it's off topic or whether you're considering including detection and assessment of misinformation and disinformation about vaccine safety and strategies to address that as part of your report.
I think it's a critical topic about what the role of misinformation and disinformation, counterbalancing the incredible systems that are in place or that could be improved upon. So I think communication and communication is a key topic, and within that, how to both promote accurate information and our discussions will certainly include. I'm not sure what role and report it will be about countering, to what extent to counter misinformation as well.
Thank you.
Well, obviously, there's lots of work still to go on the efforts of our safety committee. If there are other comments, we'd be happy to have those now, or you can put them in the chat, or certainly reach out to Rob or Steve or to Ann and I. Would be happy to get those to the subcommittee for discussion. All right, well, thank you all very much for your participation to this point. We have reached time for our first break. It is now 2:58 p.m. Eastern Time, and we will now go to break. We will return promptly at 3:15 p.m. Eastern Time. I'll make an announcement 30 seconds or a minute before we start back up, and we'll jump back in with innovative actions to improve adult immunization. Thank you all for joining us for day 2 of our February NVAC meeting.
produced by the U.S. Department of Health and Human Services.